Well, good afternoon, everybody. Thanks for being here. Today we have Marilyn Finkelstein, who's the program manager for addiction services at the IOL. So we're very pleased to have you. And she's a graduate of UConn, where she received her BA. She got a master's degree from Springfield College, and she's currently getting a doctorate from Southern Connecticut State University. And today she'll be talking about understanding motivational interviewing and how to utilize this in patients with substance use disorder. So thank you very much for being here. I know you're on vacation in Florida. We're all jealous, but we appreciate your time. So I'll hand it over to you.
Thank you so much. I hear it's like 60 there though, so not bad, or 65, right? So I'll try to bring home some of this 80-degree weather. And this talk will go well because I am in the happiest place on earth, according to some people, Disney, or the most expensive place on earth if you have children. Depends how you look at it. So, but nonetheless, I am very, very happy to be with you. Thank you for having me and letting me talk about something that I'm super passionate about and find extremely useful in working with patients with substance use disorders. You know, I've worked in every level of care in the almost 18 years now that I've been doing work in addiction. So a lot of times people have said to me over the years, you know, why do patients listen to you so much? Or how do you have this, you know, way with patients, and they do, you know, they follow your treatment recommendations, this and that. And besides all the swearing I do at them, there's a lot of that. It's also because I use motivational interviewing, because this skill set is actually more complicated than people realize. I think it tends to be simplified, is sort of, you know, this, okay, well, motivational interviewing is meeting patients where they're at. So yeah, we all do that, you know, okay, I do motivational interviewing. But it really, there's a lot more. And so today we're just going to kind of go over some of the intro, some of the basics, because really there's a lot of components to this, so much so that I am doing right now a training for the whole behavioral health network for Hartford Healthcare. So I'm the lead of that motivational interviewing committee, which is a part of a larger zero opioid overdose committee. So and that is like an in-depth training. So I'm just going to kind of go over, you know, the basics, just to give you guys an idea. And also I am doing this as part of my dissertation. So it's also, I think that's how much I really value this and think it's important. So we can get started. So in terms of motivational interviewing, it comes, I'm sure you guys know, from Miller and Rolnick, right? There's sort of the guru. But also, if you guys haven't gotten the book, David Rosengren, so he wrote the Building Motivational Interviewing Skills. So that's a really good book. You know, when I was putting together the training with my little, you know, team at Hartford Healthcare for our larger training on motivational interviewing, I did some consulting with Yale, and that was one of the books that they really liked and suggested that I look into for our training. So it's really a good book. It breaks things down. It's user-friendly and has, you know, in-depth sort of chapters on motivational interviewing, but something you can follow along and that's useful, and you don't feel like, oh, I would never use this with my patients. You know, sometimes you get those things where it just seems unrealistic, but it's a good book. So David Rosengren, Building Motivational Interviewing Skills, is a good one. And so just in a quick, we can start, I'll look at the chat, I'll put up on the side so I can see, or just by like a show of hands. So true or false, I like to start with just sort of seeing where people are at. So true or false, motivational interviewing is really just about telling people what to do with about their addiction. True or false? What do we think? You just throw it in the chat. We got a false. Good. Good. All right. You guys passed first core. All right. 100%. Oh, 1000% false. Yes, Heidi. Okay. Good. 1000% false. Right. That is not what motivational interviewing is about. True or false, a lot of motivational interviewing concepts are drawn from other people's theories, writings, and research. We think. True or false? See one false. It's okay if you're not sure about this one. So this one is actually true. So it is, yeah, it is drawn upon from other, you know, mixture of different theories, you know, psychology and things like that. So that actually is true. So I'm going to pull up, now that we did that, let me share my screen. I'm technologically special, so bear with me. And we will start. Okay, can people see this? One nod or one thumbs up? Okay, I got a nod. Thank you. Perfect. All right. So I title this one kind of back to basics. So we're just, like I said, going to start with the basics and kind of, and feel free if you have like comments or questions, just jump in. I'm not that formal where you need to, wait till the end. I'd much rather have a discussion. So all right, so what is motivational interviewing? So motivational interviewing is about change and how to help facilitate and not direct the change. And again, this is easier said than done. So we as, providers, whether that be, a doctor, a social worker, a psychologist, a PRN, we have experience, we have education, right? And how to help patients who have substance use disorders. And we want to help. That's why we're in this field, right? We got into this field to help others and try to, improve patient care. So we get excited and we want to patients to do well, but it's really their journey. And so I encourage you to think about it as, we're a guide on their journey. And so as guides, we have to give them information, right, about their choices. But at the end of the day, it really is their choice. It's not ours. And so that can, again, be hard to do if you have a patient saying to you, I'm not really ready to go to rehab. I'm not ready to go to detox. Actually, I don't even want to do an IOP or, an outpatient. I think I'm going to go back out and use. I'm just not ready. So that's hard to say, okay, sure. It's uncomfortable because, well, they may not come back. They may overdose. They may, right? So even though you don't, want that for them, it's their choice at the end of the day. So it's more about, okay, if you're going to go back out and you're not ready, how can we at least reduce risk? How can we reduce harm, right? Can I give you the number for a clean needle exchange program near you? Can I give you some Narcan to take with you, right, in your hands before you leave this meeting or the hospital setting, wherever? Just ways to reduce some of the risk. And that's really, meeting them where they're at. And so the work is collaborative and patients really, really respond to this. And because over time, it does increase their motivation, because so many patients have said to me over the years, well, I didn't, follow through because I wasn't ready. And that's all, the provider told me to is, oh, I had to go to rehab or I had to do this. And I just wasn't ready to do that. So I didn't go. But if we can be more collaborative with them and figure out, okay, what are they ready for? Maybe they are ready to, like I said, use clean needles, or maybe they're ready to get in on 211 and get into a shelter instead of living on the streets, or maybe they're ready, to sign up for food stamps and try to get food and some basic needs met. Wherever we can kind of get in with the patient is really, really important. And they appreciate that, because then they feel like, okay, this person's not one more provider just trying to tell me what to do and think they know me. Because motivational interviewing is really understanding that the patient knows themselves the best. We don't. So does that all make sense? Okay, so please feel free to interrupt if you have questions or thoughts. So let's talk about the foundation. So ambivalence around change is common, and we see this all the time, right? Especially in methadone clinic, you guys certainly see ambivalence around, do I want to fully become sober? Do I not? Do I want to go to treatment? Right? Do I not? All these things, even around dosing, right? Do I want to go up on my dose? Maybe it's time for me to go down a little. And so ambivalence does not mean somebody's resistant. I really get frustrated when I see in charts, when I get called to do consults, whether it's at the main hospital or on my own inpatient unit at the IOL, and it's, oh, this person's resistant, or they're not complying. And those right there, my antennas kind of go up. Okay, well, let me find out more about that. Why? Because ambivalence can change within minutes and hours. We have had patients come in to group and, at 1 o'clock and they're feeling great. And by 2 o'clock, they're like, I don't know if I can stay here the rest of the day. I don't know if I'm ever going to come back. I mean, we deal with that all the time. And so it's about kind of working with that and saying, okay, well, let's talk about it. What got you thinking this way? What changed from 1 o'clock to 2 o'clock that you're feeling a little more ambivalent now and you're unsure about this treatment program or your recovery? not responding in a way that's, oh my gosh, if you leave, you're going to overdose or you're going to, and kind of getting all hyped up. That's not really helpful for the patient and helpful for your engagement with them. It's, remaining calm and talking about that ambivalence and seeing if you can maybe either problem solve or kind of motivate them to stay in some way that they feel comfortable with. As we know, change is definitely not linear. So I talk a lot about this with my family support group I run every month, because parents or loved ones or partners, right, will get really excited, obviously, if their loved one is starting to get better and they're sober and, they're getting a job and they're taking their meds and their, mood is improved and all this stuff. And then something happens, whether it's a relapse or they stop taking their meds or something and they feel frustrated. So I always say progress, not perfection. So we have to remember that, right? That we're going to take 5 steps forward and there might be 1 or 2 back. And that doesn't mean all the progress forward was lost. It just means we have to figure out what went wrong and kind of tighten that up. And that goes into the next one, which, readiness to change is not fixed. So people can certainly be super unmotivated one day and then after a good talk with a clinician or a provider, feel a little bit differently. We even see this around medications. Somebody may come in and they'll say to us, "Oh, I don't want any MAT, not ready, or I had a bad experience in the past." And if they're, we know it would be best for them just in terms of protecting them from overdosing. We're not going to force them. Obviously, we always tell them it's, optional. It's not mandated. But can we talk about what went wrong? Why didn't you like it? Or, what happened? How did it make you feel? And maybe there's a medication in MAT that, wouldn't make you feel that way or that you'd feel a little more comfortable with. And so if they're not ready for something, it's not like it's lost. You can always keep, as long as we keep that door open in a very curious manner, not a judgmental manner, that's super important, then patients usually respond really, really well. And paying close attention to their readiness so that you can adjust your sessions and engagement. So if somebody is really kind of closed off, in super pre-contemplative stage of change, not ready, then you going in and talking about all these programs and, wonderful resources and all these things, and kind of ready to sign them up is probably not gonna, go well. They're probably not gonna, or they may just yes you to death just to get you out of there, and then they won't follow up with anything. So kind of just gauging where the patient is at. And I have, after we'll go through some sort of tips I've put together that I use when I teach residents and kind of go around because it's, I find it helpful for them, some quick tips. So that way, where to adjust your sessions. Fixing patients, definitely not. That's not what we're here to do. So you want to avoid what's called the righting reflex, where you want to fix the problem that patients are presenting with. And again, we're all in this field because we want to help people, and that can kind of make us at times want to just do it for them, but that's really reducing their motivation and their autonomy. And then they get reliant on us, right? Then they're always going to come back because you fixed their, housing problem or whatever, which if you did, God bless you, that's a miracle. The housing gets horrible, but you know what I mean? So you want to just guide them and problem solve with them, absolutely, and support them, but not get into a habit of just fixing things for them, because then they don't learn to become independent. And that, again, that's hard to do, especially if somebody's making really good progress and then something happens and you want to just sort of take care of it for them, but they have to really you have to problem solve and figure, okay, how can you do this for yourself? Because even in our IOPs, my clinicians and I are telling patients, we are so glad you love coming here and we support you and you're doing well, but, we're not a forever thing. So we're trying to teach you how you can use these skills, right, and be independent. So when you leave us, you can continue your progress in your recovery journey. So that's why we encourage our patients, if you can get a part-time job, even if it's 2 days a week, and structure your time outside of group, or get into a hobby, that, again, structuring your time, because once you lose these 3 hours a day, for 3 to 4 days a week, that's a big chunk of time you're going to have back. So we have to practice now kind of, structuring that so you can do it more, not here. Same thing with medications, right? So a VNA may not be paid for forever by insurance. So what can we put in place to help you? Can we get you, a medication organizer for the week, and things like that. So we just want to encourage autonomy wherever we can. And patients are, worried about this, or not feeling confident, I should say, because their life has been destroyed, right, by active addiction. So they're not really trusting their decision making. They're not trusting that they can do things by themselves because they haven't, made the greatest choices in active addiction. So sometimes they need a little hand-holding in the beginning. And so does that all make sense as well? Sorry, I could pause. Thoughts, questions? Okay, I don't think so. Sorry, you're all on the side, so it's like trying to scroll. And so obviously most people, I like to just put this again, even though most people know this, the stages of change, and certainly people can go back and forth, kind of round and round with all these stages. So pre-contemplation, you are not really ready. You don't really think your substance use is a problem. And, maybe you haven't had many consequences. One of my programs is for professionals. So we have, APRNs, social workers, physical therapists, doctors coming in. Some of these people have been high functioning, really high functioning with their addiction for, 15, 20 years. So at first they did not think their addiction was a problem. And unfortunately, because of the lack of consequence, that really kind of supported, right, them in thinking that. But of course they're coming in now because things have come crashing down, because addiction is the disease of when. It's not the disease of if. It's not when things will go wrong, or, it's not if, it's when, excuse me. So unfortunately, things have, so now they're definitely in the preparation. They're, past contemplation. They know, that they have a problem. And so they're in IOP and they're making changes. And then the action stage is, it's kind of a mixture of preparation and action. You're doing what you need to do. Maybe you're going to meetings, you're going to IOP, you're going outpatient, maybe you're going to your methadone clinic, getting your meds on, consistently, giving negative drug screens, things like that. And then maintenance, you're doing what you have to do. You're keeping your appointments, you're keeping your support groups, things of that nature. And so this I put at the bottom here, this for you guys, if you wanted to look at the book. So I put the source at the bottom for that. Any thoughts on that or questions? I think there's something. Okay, no, there's not anything in the chat. I thought there was. All right, so I will bring up my other one. Let's see. Going into the tip. Okay. So these, you guys can see this too, hopefully. So the tips that I sort of put together, again, I use this a lot and we'll kind of go through them. So I always say the goal of a first session is another session or meeting. Session doesn't mean you literally have to sit down for 45 minutes and talk to someone. When I get called over to do consults at the main hospital, whether it's transplant or endocarditis units, I'm walking in and I'm probably the 12th person that patient has seen. They are not comprehending, they're exhausted, they're not comprehending. I'm not going to go into this 20-minute spiel about their substance use disorder. So I just introduce myself, let them know that, I've been called over to discuss some treatment options, but then I say, can I come back? Can I come back later today or tomorrow morning, depending on how urgent, this consult is? And 9 times out of, really 99 times, I don't think I've ever had anyone say no, but they'll say yes. And so that way you've just kind of introduced yourself. You haven't overwhelmed them with too much information, because the reality is they won't retain it. And so as long as you can establish that quick rapport and then find a way to get them to come back, that I find is helpful, because then when I go back, they're like, oh yeah, I remember you. You were here the other day, and yeah, now I'm ready to talk. And, thanks for coming back. They'll always say, I appreciate that, because, I was tired or I still wasn't feeling well. So as long as you can establish a quick rapport and get them to agree to meet you again, you're golden, you're in. So number 2, the way to get real information, as we know, is through open-ended questions. Sometimes we have to ask, right, some closed questions just to get some data. And you want to be mindful of patients' culture, race, and ethnicities, and have cultural humility with this, for sure. That's really important, because I know I'm always cognizant, especially working in Hartford, that, I am a white female coming in to, if I'm talking to someone, whether they're Hispanic or African-American or Jamaican or whatever they identify as, I'm just certainly aware of that when I'm speaking to someone. So definitely keep that in mind. And open-ended questions, a lot of times, I will even use things that at first don't seem related to substance use. But once you get a patient talking, they'll inevitably just start talking about other things that you can use, in your clinical assessment, or kind of just to figure out where they're at. So it doesn't mean you have to go in there, start asking them 25 questions about their past substance use at first, if you're trying to just establish this rapport. Don't be afraid to just, ask about other things. I've connected with people on tons of things, whether it's, food or my culture, or just different things. And it just makes people feel a little more relaxed. It humanizes things. And then that kind of opens the door for them to trust you a little bit more. And then you can start talking about, right, the meat of everything, which is their substance use disorder and how to get them some treatment. So when talking to patients, remember to be flexible. Motivational interviewing is like a dance. So if you keep in mind this kind of like back and forth, side to side, you have to move with the patient, because a patient may start out, like I said earlier, being really motivated, and then they kind of retract. So you've got to move with that and keep up with them. And so keeping in mind that it's like a dance is a good visual. And you can use this "yeah, but" phrase in two different ways. So for me, if I'm going in to talk to a patient, and if I say, we've been talking for a bit, and then I say to them, okay, well, I've noticed that you're here, and I was called in obviously for your substance use. I noticed that you have a DUI pending. It says in the chart that, your health isn't, liver isn't doing well. I can, go through a couple of things, and, I'd like to talk to you about that. And if the patient says, yeah, but it was really just because I was stressed, my boss at work, I had a horrible, boss, and I just had a few extra drinks and blah, blah, but whatever they say. But when they kind of use that, yeah, but, and then their addiction, or right, addictive brain starts minimizing things, that just clues you into where they're at. And then you can figure out how to adjust that quote session or meeting with them. So does that make sense? It kind of like lets you know where they're at. And then you can flip it and use it the other way. So if a patient says to you, my wife's mad at me, my kids are barely talking to me, I'm not sure if I can go back to my job, I just don't know what I'm going to do, I'm not sure, why this is all happening. You can flip it, and in a curious manner, because we certainly don't want to be shaming, because our patients are really, really sensitive to shame and guilt because they have so much of it themselves. But you can turn around and say, yes, but I'm wondering if it's because I noticed you came in and, your drug screen was positive for cocaine, and I bet you're not the same person, when you're using as opposed to when you're sober. Has that been happening more often lately? Have you been using more? Maybe your family's noticing that change. So you see, you can use that in a curious manner and not accusatory. I mean, we know obviously drugs and alcohol change someone, but it's just important to make sure you're doing it in a very just curious and non-judgmental manner. And then you can kind of use that phrase yourself. So does that make sense to use it in two different ways? Any questions on that? Or I know first when I say this, people kind of look at me like, what is this lady talking about? But it works, I promise. Okay. So number 4, listen and reflect back. This is sort of like, well, obviously everyone does that. But it's just something to keep in mind. It makes the patient feel heard. Also, it gives them a chance to make any corrections. And especially if you have somebody that comes in often to your, programs, or they're kind of, we say kind of like frequent flyers, right? So sometimes you're comfortable with patients. I know I do, right? And sometimes you can anticipate almost what they're going to say. So even kind of just checking yourself, and just saying, oh, did I hear this correctly? Or did I make, I want to make sure this is what you're going to say. And, patient may say, yeah, that's exactly what I meant. Or sometimes I've reflected back what a patient has said, and they're like, no, now that you say it, that's actually not what I really mean. So it's always good to double check. Or you may anticipate what they're going to say, and they may say, no, that's not actually what I was going to say. And it gives you a chance to say, oh, I'm sorry, I shouldn't have jumped the gun. You please tell me what you mean. So just doing that gives them a chance to make sure they know that they're being heard. In terms of number 5, remember the last statement you say to a patient can be powerful. So I've done this on purpose and I've done it by accident. I've certainly done it on purpose in terms of, if I get called to the emergency room and there's been patients where they're refusing to even do a phone screen for a detox or rehab. And there was one patient, they called me down. They said, can you just try to talk to him? We're really worried because he's so high risk. He just came in off the street, off an OD. He has nowhere to go. He'll go back on the park bench and he may not make it if he ODs again. So I said, sure. So of course I came down. It's the beauty of just being across the street. So I walked down and I talked to him, so I went in and kind of established that rapport. I didn't start, I didn't go right to it at first, and kind of just chatted with him. And then I said, okay, well, just so I understand. So I kind of did the reflecting back. So just so I understand, you're telling me that you don't have anywhere to go, because no one will take you back because of your active addiction has kind of destroyed these relationships. And you don't have food, you don't have, anything other than what you came in with. And you're also refusing to do a phone screen for rehab, which takes your insurance, and you could have free housing and food for 28 days. Like, is that what I'm hearing? And then he was kind of like, oh, yeah, I guess I could go. I would at least get housing and food. Yeah, you could. It's something. So, and then so he did the phone screen, and so sometimes you have to just meeting patients where they're at. And sometimes that means just meeting their basic needs. Maslow's hierarchy of needs. It's really hard to focus on other things if you don't know where you're laying your head down at night, if you don't know where you're showering, don't have food. And I'm not one of those people where it's like, oh, people have to be really motivated to go to rehab and this and that. No, I don't really care how a patient gets to rehab, because a lot of times that external motivation will turn into internal motivation once they get there and their minds and bodies are able to clear up, right, from all the drugs and alcohol once it's cleared out. So I don't really care how somebody gets there. So I think, however we can get to a patient to motivate them is what we need to do. And he ended up going to rehab, coming to my program, and he was sober for a really long time, actually. So you just never know. And there's also been times where I don't know, I've said stuff to patients where they're like, oh yeah, what Marilyn said to me really stuck. And then I'm like, oh crap, what did I say? Like, that could go either way. So, and then, but so sometimes you just don't know what will stick with a patient. One time I just was reminding someone about his daughters, and we were just kind of talking about, I wasn't trying to use them as like leverage. And then he was like, after you left, I just really remembered that throughout the rest of my inpatient stay, and held on to that because you're right. And I needed to hear that. So I was like, oh, great. Okay. So just remember that the last thing you say to somebody can be powerful. Amplified reflection. This is exaggerating the point that a patient is making to help develop more accurate insight. So this is a way to, I say, kind of be a little bit of an ass and then get away with it. So like if a patient comes in and they're like, I haven't been sleeping, and they say this, for 2 weeks in group, I'm not sleeping, I'm irritable, blah, blah, blah. And then they come in, a week later and they're like, actually, I slept last night, I feel really good, and my cravings are down. And you're kind of, so of course you ask, right? You're like, oh, well, what changed? You haven't been sleeping for weeks. And they're like, oh, well, I took the medication that the doctor gave me. So then I was like, oh, so you took the medicine that you're supposed to take to help with sleep, and it helped with sleep. Excellent. Like, that's what it's supposed to do. So like, yeah, I know when you say it like that, it sounds stupid. I should have done this the whole time. So kind of just reflecting back to them, the point in that instance that taking meds was, what he needed to do. And so you can use that to your advantage. And it can be done with other things too. But does that make sense? So kind of just amplifying things back to them. In terms of a scale 1 to 10, I like this a lot. So people use this with suicidal ideation. Okay, how often are you thinking about it? How intense are the thoughts, right? All these things about suicidal thoughts. But this can be done with cravings. I think it's really important to try to be positive wherever we can, because recovery is just such an overwhelming journey. And so if a patient comes to your sessions, your groups, and they, you say, okay, how are your cravings today? And, did you have any substance use? And they say, oh, no, I didn't, but my cravings are really bad. They're like a 9. And so, okay, you do some planning, right, around relapse prevention and all that. And then they come back the next day and you say, okay, how, did you use? How are your cravings? Say, well, they're still at an 8. They're not, they can say they're not great. You could say, well, yeah, that's not great. We better do some more planning. It's still at an 8. Or I would encourage you to think the opposite and say, you know what, that's wonderful. It went down a point. So how did it go down from 1 point? Like what worked? How could we build upon that? And maybe by the next time you come down, it could be down another point or 2. So I really just like trying to be positive wherever we can and, build on what is working for the patient. Because a lot of times these patients are just so used to negativity and shame and guilt that anywhere we can try to be a little positive, I think is something we need to do. Number 8, being empathetic, supportive, and directive. So obviously we're not going to be argumentative. So because that's just going to reduce the likelihood of behavioral change. But you also need to be able to call patients kind of on their bullshit, too. That's what they need. And that's in this disease, what you need to do. But you have to find your own groove. So I'm super direct, patients know, but it's out of a loving place and they know I'll do anything to help them. But you have to just be, find your way to be directive and call them out, but still in a supportive way. Because you don't want to come across like you're being mean to them and shaming them, because then they won't come back. And so that can take time for people, especially newer clinicians, I find, to get their groove in that if they're going to be in the substance use fields. But empathy goes a long way. Another part that's part of my research and dissertation is empathy and motivational interviewing. Actually, I think in our field, there's, I know there's a lot of burnout, and empathy can be difficult in this population for providers because it's a disease that has really unpleasant behaviors and it can be frustrating. So I think it's really important, though, to not lose that empathy and remember that, these patients are humans that didn't wake up and want to destroy their entire lives and bodies with this disease. So anytime we can be more empathetic or keep that in the forefront, I think is really important for these patients. Adjusting to client resistance rather than opposing it directly. So working with the ambivalence, giving treatment options, making them feel like they have a decision. This is really, really important. A lot of times I will go, again, even on my own inpatient unit, and they'll say, okay, come over, this patient's resistant, they won't go to rehab. So here we go with that word, right? They're not compliant, right? Those kind of negative words. They just are refusing to go. So, I'll go over, talk to the patient. Okay, I hear that the team here is recommending rehab and, you don't want to go. Why is that? And if you just have a conversation with the patient, I can't tell you how many times, one woman recently told me she had tried to go to a rehab, but when she got there, her drug dealer was there. So that wasn't going to work for her and she didn't feel safe. So she left. Another gentleman, he had sexual assault in his history of being a victim. So he did not want to be in a room full of men. So that makes sense to me. I certainly wouldn't be jumping to go to an all-male rehab with that either, because it was a very recent trauma. So if we just take time to talk to patients and figure out what that ambivalence is about or why they're saying no, then I think, we can certainly come up with a different plan and making them feel like they have decisions. So, they don't have to go to a rehab necessarily just because they were using every day. That's another thing, sometimes the team will be like, well, they have to go to rehab. They were using every day before they came in, to our inpatient, psychiatric inpatient. Well, no, they don't. Maybe they just need a PHP or an IOP. And if that's what they're really motivated for, because, other patients have said, look, I would love to go to a rehab, but I literally can't afford it. I'll lose housing. I have to pay, I have kids, I have a mortgage, but I could make my schedule work, for IOP. And I would love to do that to get started, on my recovery. So great. Then we need to meet them where they're at and, make sure that happens so they can start getting some support for, the recovery journey. So I think it's just really important making them feel like they have a decision in the process, because then they're more likely to stick with it and follow through with the recommendation. I think there's something in the chat. Let's see. Jeremy, do you have patients write down their 1 to skill ratings and then show them how it's decreased as a visual? Oh, yes, that's a wonderful point, Jeremy. Yep, you definitely can do that. Visuals are great. Any kind of, yep, journaling, keeping notes. Sometimes too, we'll just keep like the notes that we've taken in groups and kind of reflect back to them. Like, hey, on this day you said it was an 8, or this day you said it and then it went down to a 6 or a 5. And also you can have them keep a little journal too, or like a sheet, just like a mood chart. You can do one for cravings, similar to like what I did a mood chart with one of the patients recently in my professionals program, and she found it super helpful to relate to her cravings and her relapse, right? Because a lot of times mood swings and things like that are triggers. So that's a great point. Yes, you certainly can do that for sure. And then labeling. So we don't get into label. I just put this because, you know, unfortunately not everybody's versed in addiction. And so especially, you know, residents are not always right going into addiction treatment. We don't use labels. If somebody wants to label themselves, like if they go to AA a lot or NA and they feel comfortable saying, hi, I'm so-and-so and I'm an alcoholic, and that's what they like, then that's fine. We're not going to say anything, but I'm not going around there. My clinicians are not like, well, this is Sarah and she's an alcoholic, you know, no. We're not doing that kind of labeling. I don't think it's necessary. I think, you know, sometimes it's just hard for patients, especially I run also a younger person's program. And so those younger people in that college age range are really struggling to even accept they have a problem and that they're different from all their other friends that are using so much alcohol and weed and other drugs, right? And they're not in treatment. So I just feel like labeling is just another kind of layer. But in my professionals program, I certainly have people, because a lot of them go to, you know, AA or NA, and that's how they feel comfortable identifying themselves when they introduce themselves to new group members, and that's fine. So I would say just do what's comfortable for the patient. So I can stop sharing. So that was a lot of me talking. So I just wanted to give those two kind of intro, because again, there's a lot of we have like a 9-month training on this, so I didn't want to get too in depth on it. But I certainly would be happy to answer any questions, or let me know what your experience has been with MI or frustrations with MI. We certainly talk about that too. In the training that I do, we have a mentoring session where we kind of talk about how have these skills been used over, you know, the past few weeks, and have there been any struggles, and we can kind of talk through that, because it doesn't always go the way you want it, right? It can be frustrating. So happy to answer any thoughts or questions. Or now you're all just perfectly trained in MI and you're ready to go. And all patients will be listening to all your recommendations.
Hi, I have another question. This is Jeremy.
Hi.
Hi. I've heard people who are like really like into like cognitive behavioral therapy, and they're very, very like science focused, and they claim, which I don't think is accurate, that motivational interviewing is not evidence-based for opioid use disorder. Only cognitive behavioral therapy is. So I'm curious if you know, if you've heard people say that, and if there's like things that you cite or background research about specifically using it for opioid use disorder.
Yeah, that's interesting. I have not heard that. It's actually being used a lot in different, a lot more different medical settings. So like I know there's definitely some literature that I'm using in my review for respiratory therapy has been using it. And so I guess I'm a little, why would they say that's interesting that it's not, why is opioid different than any other?
Yeah, I think they're just like have a very high standard, and they want 1,000-person studies specifically showing it to them in a certain way. And
yeah, I think, right, I see what you mean. I think it's because, so motivational interviewing, right, Jeremy, it's a skill set. So it's not this like where there's been, I think, you know, randomized controlled studies, right? Like all these studies about it, you know, proving, because all these data, right? The scientific data like it would in some of those at like MAT, like if we're looking at methadone or Suboxone or right, things like that. So is it different in that aspect? Yes. Doesn't mean it's less effective. No. I mean, I think there's a ton of literature on how effective it is. And, it did get its start in addiction, of course, with Miller and Roenick, but there's a lot of just different research and literature supporting how it motivates patients to make a change in any kind of behavioral change. I mean, this is used also with eating disorders. It's used with gambling addiction, right? Sort of all those things that are affecting, right, that reward system in the brain, that pleasure system. And so I just think it's a really great skill set. I think, unfortunately, because it's not it's more of a skill set, I think it tends to be looked down upon maybe by some of those people that are super hardcore. But I just find it so useful over the years, and so that we have this whole committee on our opioid overdose committee that our vice president has put together, that we're using motivational interviewing. I mean, that's how much we believe in it, that it's to reduce deaths from opioid use. Because if somebody's coming in and, like I was saying earlier, if they want to go out and use, they can go out and use, but at least if we can meet them where they're at and get them to take Narcan with them and take, how many people have overdosed and passed away, unfortunately, just because they were using alone. So we can get them to at least not use alone, and take some Narcan with them. To us, that's a win. That's motivational interviewing right there, meeting them where they're at. If we can just save one life, I think it's worth it. Is that a hen behind you, PS? Can we talk about the hen?
Yeah.
Or the chicken?
From an estate sale.
Okay. Oh, you have two? You're covering a second? Oh my gosh. Okay. That is so funny. Love it. Love it. Thank you, Jeremy, and your hens.
Sure.
Any other thoughts, questions? Well, I certainly don't want to belabor it. So, because I'm big on not wasting time, and certainly can give you guys time back for your lunch and to sort of regroup before, I'm sure you guys have a million patients this afternoon. So thank you very much. Appreciate you all, and hope you have a fabulous rest of your day.